Hi, my name is Salwa Sawaid and I'm a third year nursing student at the University of Canberra. This is my video application for the Canberra Health Services New Graduate Program 2026. Throughout my nursing education and my time working in ED, the NSQHS Communication for Safety Standard has been a pinnacle in my clinical practice. During my clinical hours in ICU, I was caring for a young patient who was an exchange student with limited English skills. His family had travelled to Australia to be with him and were understandably distressed, seeking regular updates and wanting active involvement in his care. As a student, working closely with his primary care team, my role was to support communication between the treating team and the patient's family, while also ensuring the patient care was delivered safely and with cultural sensitivity. By joining MDT meetings, I provided concise clinical handovers, highlighting the need for translation services upon the parent's arrival to collaborate in his plan of care. I documented appropriate details to share with the family through use of translation services and took the initiative to provide the family with a communication board and photos of ICU equipment so they could communicate with nursing staff without translation service assistance. I practiced active listening, allowed time for their questions, and relayed concerns back to the team via documentation and clinical handover to ensure transparency and continuation of care. Through this, the family was supported and included in the care process. They were able to provide key details on the patient's medical history that were previously unknown to the treating team, and were able to reassure the patient and provide support when sedation was titrated. This experience reinforced for me how critical interpersonal communication is, especially when patients are unable to advocate for themselves and families are in need of both communication and emotional support. During a clinical simulation activity, I encountered a situation where a medication was almost administered at the incorrect dose due to a charting error. My primary responsibility in this scenario would be to ensure the immediate safety and well-being of the patient and manage the incident with transparency and professionalism. I would first assess the patient for any adverse effects and escalate immediately to the required personnel. I would monitor the patient's vitals and implement any necessary clinical interventions based on the nature of the error. Using open disclosure, I would inform the patient, explaining what happened, the possible effects, and what steps are being taken to ensure their safety. I would document the error and complete an incident report in line with the CHS procedures. Following this, I would reflect on the contributing factors and seek guidance through supervision or education to improve my practice. I always adhere to safe medication administration practices, including the 8 rights, double-checking high-risk medications, and clarifying unclear orders. This approach supports patient safety and professional accountability. During my time in ED, I've often been included in the care of multiple patients with varying levels of acuity. The pace is fast and demands are high, and I've at times felt overwhelmed by the number of competing priorities. My responsibility in these events is to manage my time effectively, ensure safe patient-centered care, and escalate concerns early to assist in my ability to manage the workload. Utilising a team nursing approach, I began by communicating with my colleagues of each patient's clinical status, developing a plan and delegating tasks evenly. I prioritised my tasks to address the most urgent needs first, utilising clinical pathways and NCH procedures to guide my decision-making and remain diligent in my documentation. When appropriate, I took brief moments to pause, breathe and reset, and we checked in on each other periodically to ensure all team members took the time to do so. After the shift, I debriefed with my colleagues to reflect. Plans change quickly in ED. By being flexible and communicating effectively and reprioritising tasks, I was able to contribute to a collaborative deliverance of safe and timely patient care despite the intensity of the shift. The NSQHS and work health and safety policies ensure physical and psychological safety for everyone involved in care received by the CHS. Throughout my clinical placement in custodial mental health, I worked with patients who were incarcerated and experiencing acute psychosis. The environment required heightened attention to safety, de-escalation, and trauma-informed care, all while maintaining professional therapeutic relationships and ensuring compliance with said standards to ensure positive patient outcomes. I met the NSQHS standards by adhering to AMC and CHS policies for managing aggression and escalation and adherence to PTO and FPTO requirements, building trust through respectful and non-judgmental communication, hand hygiene and PPE, conducting supervised depot medication administration, considering each person's mental health needs in context of their incarceration, trauma history and risk of self-harm, and documenting behaviours of concern, accurately and actively communicating with multiple teams, including custodial mental health, forensic teams, correctional officers, and ACT magistrates. I completed mandatory work health and safety training specific to custodial settings, including managing occupational violence and trauma-informed care. As a result of these actions, I was able to contribute to a safe and therapeutic environment where my respectful approach and awareness of both clinical and custodial safety deepened my understanding of how patient-centred care and staff safety support positive patient outcomes. The CHS values, we are reliable, progressive, respectful and kind, encompass my years working for the CHS so far and inspire my future nursing. During my aforementioned time in the ICU, I was able to incorporate these values in a holistic approach, not only for the care of my patient, but the involvement and care of his family. Throughout the 4-week allocation, I built a relationship that resulted in trust, influencing family members to find me on the unit when on a different allocation, to raise concerns, ask questions, and communicate to his treating team on their behalf. Although I was not directly involved in their son's care each day, the continuation of trust instilled a sense of pride in the work I did during my time in the ICU and contributed to his successful continuation of care. I wanted to thank you for your time today, and I look forward to starting the new grad program in 2026.